Greetings, Dr. Monmass and N306 students. My name is Tony Bowman-Boler. I am the co-instructor for this course, and I have put together this PowerPoint presentation on diabetes mellitus. We will briefly be covering the pathophysiology of diabetes, management of the disease, and some pharmacological implications for the treatment of the disease. So during the presentation, I want you guys to go through a few slides and kind of in between, maybe every 10 minutes or so, I want you to pause and stop the presentation and do some reflecting and thinking about what we talked about or what we covered so far and how it relates to what you know already. So when we're studying for any course, I want you all to briefly think on what you already know about a particular topic that you are studying. Oftentimes, we do not realize that we all have some sort of knowledge stored away somewhere in our memories. So I encourage you to jot down what you think you may know already about this topic prior to engaging with the other materials that you have, such as your textbooks, your online reading and quizzes. Write down what you feel like you already know about diabetes. This PowerPoint will serve as a brief overview and supplement to your textbook readings and all of your other coursework and assignments. So let's dive into this presentation on diabetes. There are a few types of diabetes that we are going to be covering during this presentation. There's type 1, type 2, gestational, and stress-induced. So some of the pathophysiology of type 1, it's a chronic autoimmune disorder, absolute insulin deficiency, most common in children and young adults. This type of diabetes requires lifelong insulin therapy. It's an autoimmune process. It's usually genetic predisposed plus environmental triggers. Autoantibodies attack the pancreatic beta cells, involves immune cells, the T lymphocytes, and B cells. There's a gradual destruction over months or years on those cells. The role of the beta cells in glucose homeostasis, located in the isolates of Langerhans in the pancreas, they produce and secrete insulin in response to glucose. The role of insulin is to allow glucose uptake into the cells for energy. So when those are destroyed, there's no insulin, and consequently, there are an increase in glucose or hyperglycemia. Key pathophysiological features: complete lack of insulin production, increased blood glucose levels, lipolysis and ketone production due to fat breakdown. This is where that DKA comes in at. So the risk for DKA due to ketone accumulation is prominent in type 1. The clinical presentations of type 1 diabetes is those polys. So polyuria or frequent urination, polyphagia, increased hunger, and weight loss, fatigue, blurry vision. This all may be present with diabetic ketoacidosis. How do we diagnose type 1? Some of the blood work or some of the blood tests that we may do is a fasting plasma glucose. In type 1, it'll be indicative of greater than 126 milligrams per deciliter. Random glucose greater than 200 with symptoms. Your hemoglobin A1C is going to be equal to or greater than 6.5. Presence of autoantibodies. This is your GAD1A2. Some of the long-term complications are microvascular, and that's where you get to see your retinopathy, your nephropathy, and your neuropathy. Some of the macrovascular will be in your cardiovascular system. These are your MIs and your strokes. Poor glycemic control. This increases the risk. How do we manage type 1? Insulin replacement therapy, blood glucose monitoring, carb counting, very important. So we want to get a dietitian on board with these, our patients that have type 1. Regular physical activity and diabetes education and psychosocial support as well. So in summary on type 1 diabetes, type 1 diabetes is an autoimmune disease, results in insulin deficiency and hyperglycemia. Lifelong management needed to prevent complications with type 1. Moving on to type 2 diabetes, we're going to do an overview. So this is a chronic metabolic disorder. It's characterized by insulin resistance and relative insulin deficiency. So we have two things going on here. We have resistance of the insulin and also a deficiency in insulin production. Most common in adults. It's increasingly seen in children, and we need to ask ourselves why. Why is that? Why are children now being diagnosed with diabetes type 1? And we'll talk about that. It's a strong link to obesity and sedentary lifestyle. There's the link. Insulin resistance. Targeted tissues are muscle, liver, and adipose. They respond poorly to insulin. Glucose uptake by the cells is impaired. Liver continues gluconeogenesis despite high glucose levels. Leads to elevated blood glucose levels. So our beta cells here are at a dysfunctional state. Pancreatic beta cells initially compensate with increased insulin production. But over time, beta cells become exhausted due to all that carb intake. And over time, the progression, we lose that beta cell function and insulin secretion. And this contributes to worsening hyperglycemia. We have patients that most often come in and they've been feeling bad for quite some time. They may have been in this metabolic state for quite some time. And then we get them and they haven't been to the doctor in over a year or two. We do get that first hemoglobin A1C, which we know that monitors how they've been eating over the past 2 to 3 months, and it's at a 13. So we know that didn't just happen, so that's when we get our patients that has probably been in that metabolic state for some time, and now they are they have diabetes, which they more than likely probably have had it for some time, just haven't, been taking care of themselves and going to the doctor, getting them preventative treatments done and checking up on themselves regularly. So that's something that we have to educate our patients on, coming to see their doctor regularly, getting them yearly physical exams, getting that blood work done at least once a year if they're normal. Some of the risk factors: obesity, particularly around the midsection, a family history of diabetes, physical inactivity, ages greater than 45 years, hypertension and hyperlipidemia, history of gestational diabetes. And so the clinical presentation of type 2, we see again the polyuria, polydipsia, and polyphagia. Fatigue, blurred vision, frequent infections, slow wound healing. Sometimes most patients are often asymptomatic and discover that they're diabetic via routine labs. But in my experience, when you get to asking your patients questions and gathering all your data, asking them questions about their past medical history or how they've been feeling. They usually most of the time say, oh, I just been tired, but I work a lot. And this, they've been dealing with this for, when I say this, that metabolic state, being in that metabolic state for so long, they charge it to, oh, I just been tired because I do work a lot. And then sometimes that may be true, but oftentimes we find out that they have actually been diabetic for so long and just didn't know it because they haven't been to the doctor in so long and had those routine labs done. So we want to make sure we educate our patients on getting that preventative care. How do we diagnose type 2 diabetes? Your fasting plasma glucose greater than 126 milligrams per deciliter, random glucose greater than or equal to 200 milligrams per deciliter with symptoms. Your hemoglobin A1C is going to be greater than or equal to 6.5, and your oral glucose tolerance test, or OGTT. Some of the long-term complications, we have that retinopathy, the nephropathy, and the neuropathy. The microvascular is the heart disease. That's when you having those MIs and your stroke, and peripheral vascular disease. Increased risk with poor glycemic control. Some management principles, lifestyle modifications. We want to get that diet and exercise and weight loss on board in conjunction with medication management. Oral hypoglycemic agents and or insulin, blood glucose monitoring, control of blood pressure and the lipids. Diabetes self-management and education and support. We want to get dietitian on board with us, a nutritionist on board with us when we get our patients that have the high hemoglobin A1Cs, even our pre-diabetic patients. We want to get the dietitian or nutritionist on board to help them with those lifestyle modifications. Pathophysiological summary for type 2 diabetes. With type 2 diabetes, there's insulin resistance coupled with impaired insulin secretion, and that adds on to increased hyperglycemia. Lipotoxicity and glucotoxicity further damage the beta cells. You have inflammation and oxidative stress contributes to the disease progression. Type 2 diabetes results from insulin resistance and beta cell failure. Early detection and management are key to preventing complications, and a multidisciplinary approach improves patient outcomes. Now we're going to talk on secondary diabetes, stress-related diabetes, and gestational diabetes. Stress-induced diabetes occurs during acute illness, surgery, trauma, or critical care. Sometimes we get patients that come into the hospital that they're type 2 diabetics and they don't take insulin at home, and they wonder why I don't take insulin at home. I just take my metformin or my glipizide or whatever other medications they may be on to treat their diabetes, and they want to know why they're given insulin when they're inside the hospital. And this is the reason. Oftentimes when they're admitted to the hospital, depending on what is going on with them, with their disease processes and their comorbidities, physicians often put them on a sliding scale of insulin. That doesn't necessarily mean that they're going to be on insulin once they get discharged. It's just that the stress of the being in the hospital and things that our bodies are going through when we're in the hospital dealing with these comorbidities, sometimes they need that extra support with insulin injections. Stress hormones like cortisol, catecholamines increase glucose production. Temporary insulin resistance and or impaired secretion often happens when patients are in the ICU or IMC or in the hospital for long periods of time. This often resolves after underlying conditions is treated. So that's a good educational piece that we can educate our patients on when they don't necessarily take insulin at home or outside of the hospital. We can explain to them why they're getting insulin while they're inpatient. Moving on to gestational diabetes, or GDM. It's diagnosed in pregnancy, usually the second or third trimester. Placental hormones, your estrogen and cortisol, induce insulin resistance, increased insulin demand, pancreatic capacity, risk to both the mother, for example, during preeclampsia, and fetus. Risk factors by type. So type 2 diabetes, risk factors usually obesity, age, family history, or inactivity, or sedentary lifestyle. Stress induced. We'll see that in our patients that have severe infections, trauma, burns, or ICU or IMC admissions. Gestational, obesity, age greater than 25, familial history, previous gestational diabetes, or a large infant. What do our patients look like? During the clinical presentation with type 2, they're often asymptomatic, but there are those polys, so polyuria, polydipsia, fatigue. So with stress induced, it occurs in context of acute illness. In gestational, typically detected via screening, and they may be asymptomatic. How do we diagnose these? Fasting glucose greater than 126 milligrams per deciliter. Random glucose, that's going to be greater than or equal to 200 milligrams per deciliter with symptoms. Your hemoglobin A1C is going to be greater than or equal to 6.5. Your OGTT for gestational diabetes screening is at 24 to 28 weeks. Some of the complications across the various types. You have your microvascular, your retinopathy, nephropathy, and neuropathy. Your macrovascular, that's where you have your CVDs, your strokes, and your PVDs. GMD, increased future of type 2 diabetes risk in mother and child. So it's a correlation to having gestational diabetes, and in the future, it increases their risk of getting type 2 diabetes. So when we have those mothers and we do our assessment and we see that they have had gestational diabetes, we want to make sure that we pre-screen them and treat them as if because they are at a higher risk of developing type 2 diabetes. So we want to educate them and emphasize that importance of them coming to get that preventative treatment or being screened preventatively, so we can keep an eye on them and make sure that, you know, they're having a good diet and exercising and making sure they're keeping up with their doctor's appointments, so we can monitor them for that. Stress-induced. This may complicate recovery and critical illness. Some of the management principles in type 2, lifestyle changes, your carb counting and your meals, insulin, stress-induced temporary insulin or glucose-lowering agents. For gestational is diet and exercise, insulin if needed, and close fetal monitoring. So in summary, type 2 diabetes, that's where you have your insulin resistance, coupled with your beta cell dysfunction. For stress, diabetes, hyperglycemia due to acute physiological stress. That's where we have our patients that are possibly in the ICU or IMC. So for gestational diabetes, it's pregnancy-induced insulin resistance. Early detection and individualized treatment are key. Moving on to diabetic ketoacidosis and hyperosmolar hyperglycemic non-ketotic syndrome, HHNS. So with DKA, this is more common in type 1, but can occur in type 2 under stress. Pathophysiology here, insulin deficiency with lipolysis, ketone production, and metabolic acidosis. Some of the triggers are infection, missed insulin, and stress. Some of the symptoms, your polys, your polyuria, polydipsia, polyphagia, abdominal pain, fruity breath, and Kussmaul respirations. Some of the labs that we test to confirm DKA: glucose greater than 250 milligrams per deciliter, low pH, and ketones in the urine. With our HHNS, primarily affects older adults with type 2 diabetes. The pathophysiology of HHNS, severe hyperglycemia without significant ketones. So that's your differentiation between the two, between DKA and HHNS. One has ketones, the other one does not. Some of the triggers: infection, illness, poor fluid intake. What are some of the symptoms our patients might present with? Dehydration, altered mental status, extreme hyperglycemia. We will see upwards of 600 milligrams per deciliter. No acidosis with this one. And I want you guys to look that up. Why is that? With this HHNS, there is no acidosis. Versus with DKA, you have that metabolic acidosis. What are the labs we're going to be looking for? Serum osmolality. The pH is going to be normal. Absent or minimal ketones. How will our patient present? So some of the things we want to look out for, again, with the DKA, it's going to be a rapid onset within hours. When we do our history, we're going to find out that sometimes the patient is going to be saying they haven't been compliant with their medications or their insulins, that they may have an infection recently or an illness. Maybe the patient had just been diagnosed with diabetes and they lack the education on their medications or how to take insulin, how to store the insulin. Some of the clinical signs and symptoms are dehydration, nausea, vomiting, abdominal pain. They might be breathing rapidly, those Kussmaul breathing. Fruity breath. Mental status may be altered, may range from alert to lethargic to comatose. With the HHNS, primarily affects older adults with type 2 diabetes. Pathophysiology, severe hyperglycemia without significant ketosis. What are some of the triggers? Infection, illness, poor fluid intake. Some of the symptoms they might present with are dehydration, altered mental status, extreme hyperglycemia, upwards of 600 milligrams per deciliter with no acidosis. Some of the labs, they're going to have a high serum osmolality, normal pH, absent or minimal ketones. With the HHNS, it's going to be gradual onset, days to weeks. When we collecting our data, we might be informed by the patient that they've had an infection recently, poor glucose control, inadequate fluid intake might be some of the key data that we get from them. Clinical signs: profound dehydration. They might present with dry mucous membranes, poor skin turgor. When we're doing our neural checks, they might be confused. Seizures could be a possibility, lethargy, and coma. Some of the labs when we check, glucose might be upwards in the 600s. We're going to have a high osmolality with no acidosis. Again, just to recap the labs and diagnostics, we're going to be checking that fasting plasma glucose. And we measure this by taking blood. And then we're going to measure that after 8 hours of fasting. So that patient has to be fasting for 8 hours. And how that's diagnosed is the lab come back and is greater than or equal to 126 milligrams per deciliter. That will indicate that they have diabetes. The oral glucose tolerance test, or OGTT, this measures glucose levels over 2 hours after a 75 gram glucose drink. So we're going to provide them with a sugary drink. We're going to wait 2 hours. We're going to draw their blood, and when that labs come back, diabetes is confirmed if it's greater than or equal to 200 milligrams per deciliter. Your hemoglobin A1C, this reflects the average glucose over the past 2 to 3 months, and this is diabetes is confirmed if the A1C is greater than or equal to 6.5. Random plasma glucose with symptoms of hyperglycemia. So like the symptoms of your polyuria, polyphagia, polydipsia. So this one, if it comes back greater than 200 milligrams per deciliter, your C-peptide test assesses endogenous insulin production, useful for distinguishing between type 1 and type 2. So this particular test, the C-peptide test, this one is to assess between the two types, type 1 and type 2. Urinalysis, this detects glucose and ketones in the urine, which is helpful in identifying DKA. Autoantibodies, anti-GAD, isolate cell antibodies, and insulin autoantibodies to distinguish or to diagnose type 1 diabetes. And then your serum osmolality is elevated in HHNS. Then you have your ABGs or your blood gas. Low pH and bicarb will be indicative of DKA. We're going to move on to some of the treatments for diabetes. These medications, these are the medications that we would like for you to focus your attention on. You go through your readings and your textbooks and do your online assignments. Pay particularly attention to these ones listed in these slides. So for the first one, we have our carboys. The mechanism of action. This is a sulfonylurea. It stimulates insulin release. Indications is type 2 diabetes. This is contraindicated if they have a sulfur allergy or DKA. Some of the adverse effects are hypoglycemia and weight gain. So we want to educate our patients on those effects, the hypoglycemia and the weight gain. And we use this cautiously in the elderly, in patients that have hepatic and renal issues. Your glipizide, this is your alpha glucosidase inhibitor. This delays carb digestion. So the indications for this one is type 2 diabetes. Contraindications are GI disorders and cirrhosis. Adverse effects, flatulence and diarrhea. We want to use this drug cautiously in patients with hepatic and renal impairment. So with glipizide, when they take this drug helps delay carb digestion. So what kind of diet, or what are some of the, if any, restrictions, diet restrictions, or how are we going to educate our patients on their carb intake when they're taking glipizide? So these are one of our GLP-1 agonists. It enhances insulin, delays gastric emptying. We use this for our type 2 diabetics and those that are obese. Some of the contraindications are thyroid cancer and MING-2. Some of the adverse effects are nausea and pancreatitis. So we want to monitor patients for that are on this particular drug. We use this cautiously in patients with renal and GI disorders. And metformin. So what do we know about metformin? The mechanism of action for metformin, it reduces hepatic glucose, improves insulin sensitivity. The indications are for type 2 diabetics and PCOS. This is an off-label use. Some of the contraindications, the EGFR is less than 30, lactic acidosis. Some of the adverse effects we want to monitor for: GI upset, B12 deficiency. So we want to monitor that, particularly in the patients that are taking metformin. We use this cautiously in patients that have alcohol use and renal impairment. So we want to do a little bit of education on the use of metformin and alcohol use. Also, we want to, for our patients that are on metformin, if we have to refer them out or refer them to have certain scans done, there's some teaching that we have to do in regards to metformin and how it's taken if they have to have certain MRIs or certain scans done. So I want you to look that up and know that information. Pioglitazone. The mechanism of action, this is a PAR-Y agonist. It improves insulin sensitivity. Indications are type 2 diabetes, contraindicated in patients with CHF and bladder cancer. Adverse effects, weight gain and fractures. We'll use this cautiously in patients with hepatic monitoring. Repaglinide. The mechanism of action, it stimulates rapid insulin release. Indications is type 2 diabetes. It's contraindicated in our patients with DKA. And also is contraindicated with patients that are currently taking gemfibrozole. Adverse effects is hypoglycemia, GI upset, and we use this cautiously in patients with liver disease. I want you guys to look up why it's contraindicated with patients with DKA and also patients that's taking gemfibrozole. Sitagliptin. This is a DPP4 inhibitor. It increases incretin levels. Indications are type 2 diabetes. It's contraindicated in type 1 diabetes. Adverse effects upper respiratory infection, pancreatitis, which is rare, and we use this cautiously in patients with renal impairment, our insulins. Here are our insulin types. We have our Lispro, which is rapid acting. We have regular insulin, NPH, your glargine, and your detamir. We have listed the onset times, the peaks, and the duration. One of the nursing things that we have to remember is that when we're giving these insulins, we want to make sure that we are providing some sort of snacks for these patients, especially if we have patients that are on more than one, and especially if we have patients that are on more than one and they're on a sliding scale and they're getting long acting at night. So we just want to make sure that we have snacks provided for our patients that are taking more than one insulin while they're inpatient. Some insulin considerations. Insulin is, of course, contraindicated if they have hypoglycemia. We don't want to bottom them out. We want to use it cautiously and timing with timing with the meals, but also with other meds. Adverse effects: hypoglycemia and weight gain. We want to monitor their glucose regularly and educate the patients on hypo and hyperglycemia signs and symptoms. Some of our patient education with our diabetics. Management strategies, lifestyle. Can't stress this enough: diet, exercise, and weight loss. The medications, both oral anti-diabetics and insulin. We want to monitor their glucose, their A1Cs every 3 to 6 months. Some of the patient education goals: understand disease process and types, learn to recognize symptoms and complications and when to seek medical advice, know how to monitor your blood glucose levels via the glucometer. Or some of our patients have these sensors that they can have on their arm, and on their smartphone, it'll let them know continually what their blood sugars are. Those are becoming more and more prevalent now. Understand medication use and lifestyle management. Key self-management skills: blood glucose monitoring, healthy eating and carb counting, very important. Physical activity, extremely important. Medication adherence, very important. Managing sick days and stress. These are all key self-management skills that we want to, as nurses, make sure we are stressing and actually going over these things during every encounter with our patients. Teaching tools and resources, visual aids, pamphlets, online portals, like the American Diabetes Association. It's a lot of good information on there for our patients. Group classes and support groups. Certified diabetes educators and nurses. They're good resources. We want to empower our patients, encourage shared decision making. This increases positive patient outcomes. We want to set realistic and individualized goals. We want to get our patients on board and let them know that the power actually rests with them, that we're just there to help facilitate their healthcare goals. We want to reinforce positive behavioral changes, provide ongoing support and education for our patients during every encounter. So in summary, diabetes is manageable with education, support, and monitoring. Patient-centered teaching improves outcomes. Early recognition of DKA and HHNS is critical. Here are my references. I hope you enjoyed my presentation. Thank you so much for allowing me the time to speak with you regarding diabetes.